All right, let's go ahead and get started. Thank you, everyone, for joining the Neurology Lecture Series and a talk by Dr. Edward Rusty Novotny on developmental and epileptic encephalopathies. We are lucky to have a pediatric talk as we try to every year. And so thank you very much to Dr. Novotny for doing this. A little bit about Dr. Novotny. He did his elementary school at St. Joseph's in Upland, California. Then he went to St. Louis University for medical school and Stanford University for both his neurology residency and epilepsy fellowship. And has been at Seattle Children's for how many years, Rusty?
It would be 13 in June or July.
Okay. 13 years. So with that, I turn it over to you, Dr. Novotny.
Okay, great. So I think this is a talk that I've given before, but I think it's an ever-changing field, and I think it's really revolutionized at least my approach to epilepsy and as a pediatric epileptologist, and certainly a big change since I went to medical school a few decades ago, let's say. So what I'm going to talk about is what are now referred to as developmental and epileptic encephalopathies. I should mention I'm on some advisory boards for some pharmaceutical companies that are making some of the new targeted therapies and been involved with clinical trials for UCB, ISA, and have some grant support from CDC and University of Washington Population Health and UCB. So the learning objectives are to understand the newer definitions of developmental and epileptic encephalopathies, and we'll talk about them in a little more detail. Identify patient populations that are high risk for having developmental epileptic encephalopathies, and describe the underlying genetic and molecular causes, the management with these developmental epileptic encephalopathies, and include common etiologies, approaches to care, and more importantly now, precision therapies. So we know epilepsy is the highest incidence actually in the pediatric population. So actually the neonate is when seizure and epilepsy first often starts, which with a very high incidence, and then gradually decreases to a nadir in late adolescence, early adulthood, and then, as we know, has been escalated in incidence as a function of age. So primarily in adults, we know acquired causes of epilepsy are more common, but certainly when I went to medical school, 70 to 80% of childhood epilepsies were always described as idiopathic or unknown. But now, presently, genetics are now known to be the underlying cause of a lot of epilepsy and epilepsy syndromes, and very specific ones that we see primarily in pediatrics. So certainly have onset. So what are now referred, that used to be called benign epilepsies of childhood, which are now referred to as self-limited epilepsies of childhood. What also used to be called idiopathic generalized epilepsies are now genetic generalized epilepsies is a term that's more used. But I'll focus on one where there's a very high yield of identifying underlying genetic causes, what are often referred to as the epileptic encephalopathies. This is a great review of contrasting what was the causes understanding of epilepsy in the early 70s from epidemiological studies in Hauser, where, again, as I mentioned, a large percentage of patients identified as being idiopathic. And then we certainly stroke, trauma, neoplasms, infectious disease are very common and more common in the adult population. But if you look at this as a review by Sam Berkovic and his group in Australia, one of the things that's really revolutionized our understanding and causes of epilepsy is certainly imaging. So imaging and MR has identified a lot of pathology that we couldn't see earlier, pre-MR, certainly mesotemporal sclerosis, a lot of cortical dysplasias, and a lot of more subtle lesions MRI will be picking up. But more importantly, many of the conditions that we previously called idiopathic are now, some are a single gene or Mendelian inherited epilepsies. There are many of the epilepsies that are seen in adults, and what we now refer to as the genetic generalized epilepsies are more complex inheritance, and they're probably not single genes. But there's many other genes that clearly modify the expression and severity of individuals' epilepsy. But I wanted to focus on this group of disorders that we refer to as epileptic encephalopathies. And they actually are broken down into three main areas. So it's an epileptic encephalopathy is a condition where the abundant epileptiform abnormalities or actual subclinical or even clinical epileptic seizures themselves contribute to cognitive regression and or in my world, sort of developmental regression. And a developmental epileptic encephalopathy is a condition where cognitive and developmental problems are impaired independent of the epilepsy onset. And the epilepsy is often characterized by high frequency seizures and abundant epileptiform abnormalities on EEG. So it becomes this issue of what's the chicken or the egg? Are the seizures causing the regression or is the underlying cause? And then developmental encephalopathies, which come under other terms such as cerebral palsy or intellectual disability, is a condition where a person with a developmental delay or intellectual disability is due to some non-progressive brain state, such as a perinatal stroke or early brain injury that creates a static process that isn't going to get worse as a function of time. So those are the kind of main three categories, and the interaction between the epilepsy and the underlying causes is still being sort of worked out over time. So I'm just going to present cases that we've been involved here, both at Seattle Children's in our epilepsy genetics clinic and in many other spheres. So the first is a young boy who's now 8. His name is Uriah. He's born term, and he was identified in the first year of life to have developmental delay. He was enrolled in a process that's most states called Birth to 3 to help with monitor his development and provide him some therapies. And at 15 months, he had a generalized motor seizure with behavioral rest that lasted less than a minute. He started to be treated, and he was identified to be resistant to clonazepam and levetiracetam and even the ketogenic diet. But his seizures improved dramatically with addition of valproic acid. And then that plus lamotrigine has actually made him seizure-free. So as part of his evaluation, he had imaging. And so this is his image, which is a developmental anomaly that's a static lesion. And you can see that this is the T2 weighted image on the right, and then the T1. And you see he has what's often referred to as subcortical band heterotopia that's pretty extensive, most maximum posteriorly. And he has these fine sort of pachygyria or very more simplified cortex in the occipital posterior head regions. So he underwent genetic testing in Oregon and also in Boston. When he was 5, he saw Bill Dobbins, who's one of our neurogeneticists here, who was here, and who felt that he likely had one of the underlying genetic causes of this condition, which is either LIS1 or DCX. And most likely it was a somatic mosaicism because he had a relatively mild phenotype. He was enrolled in a research testing, and he continues to be seizure-free. He continues to make significant developmental progress, and he is in a special education setting. So he would be a good example of a developmental encephalopathy that really his epilepsy is not much of a problem. It's well controlled, and he's continued to make progress. The next is a good example of a developmental epileptic encephalopathy. So this is a boy who's now 7. He was born term, discharged from hospital at 3 days of age, and then readmitted within a 24, 48-hour period where he had episodes of tonic stiffening with apnea. He was treated with phenobarbital and diagnosed to have an epileptic encephalopathy by EEG, something called Ohtahara syndrome. And I'll show you that EEG. He had extensive metabolic studies in a trial of pyridoxine at an outside hospital, and then ultimately was referred to our epilepsy clinic at 6 months of age and was switched to topiramate with improvement. So this is his EEG that we typically see in a condition called Otohara syndrome. It's a very discontinuous burst of generalized sort of polyspike discharges with periods of attenuation. And during some of the more prolonged ones, he'll have a brief tonic or myoclonic seizure. He continued to have developmental delay. His EEG actually improved dramatically with treatment. It was identified as normal. And he came to our epilepsy genetics clinic at 13 months of age. We did an extended epilepsy panel, and he continued to have tonic seizures. And that test took a few months to come back, and the positive genetic test results that I'll review came back. The next is a now 5-year-old boy who prenatal testing identified he had a genetic abnormality. His father had a history of epilepsy in childhood. He has a term delivery without complications, and early developmental milestones were normal. In about almost 3 years of age, he was noted to have some toe walking. He was diagnosed to have a mild spastic paraparesis and had some therapies. At age 3, he had his first seizure with behavioral rest, eye blinking, and very focal facial motor movements with drooling. And his EEG had this finding that we often has fairly characteristic findings of a focal central temporal spikes that used to be called benign Rolandic epilepsy, and now we call it self-limited epilepsy with central temporal spikes. And that is what his phenotype at age 3. He was then treated with levetiracetam. He had a lot of side effects. He had a epilepsy gene panel sent that had a positive result that I'll review. And he was treated with clobazam with improvement in seizures. An MRI was normal. He was seen at the epilepsy genetic clinics at Children's Hospital of Philadelphia. His seizures began to increase and occurred daily, particularly at night. Lacosamide was added. He began to have actually developmental regression, and particularly in the areas of speech and language, he had significant disability or decrease in his function. This was his EEG. When he started having regression, he had almost continuous these spike wave discharges, particularly during sleep, where almost 80% of his non-REM sleep was included with these what are identified as really interictal discharges that are bilateral, but often switching between one hemisphere and the other. And then this is even further on, he continued to have this, what sometimes is referred to as continuous spike wave during sleep. And he, again, was referred to our epilepsy program, and he had a comprehensive epilepsy evaluation, including further genetic testing that we will review. And then finally, some of these syndromes, they overlap and they transform from one type to another. And this is a good example of a 2-year-old boy who I saw, who was born at term, had respiratory and feeding difficulties. He's admitted at age 11 for continued respiratory difficulty, was thought to have choanal atresia, admitted for 2 months of age, and he started having tonic seizures that were both focal and bilateral movements, diagnosed to have seizures based on EEG that were primarily tonic, hospitalized for 3 months for increased seizures, and his EEG showed this epileptic encephalopathy with epileptic spasms and tonic seizures. He had a epilepsy genetic panel of 181 genes that was non-diagnostic, and he continued to have multiple admissions for status epilepticus, and an exome was sent at 4 months of age, but took a couple months to get it approved before it was actually done. And then this is his EEG at 3 months, where he had almost this continuous both ictal and interictal discharges, sometimes referred to as the ictal-interictal continuum. Again, this is that occurred at a time where he was really plateaued or had regression of his milestones. And again, he was referred to our epilepsy program at 10 months of age. After that exome sequencing actually came back positive, he has continued to have seizures despite at least 4 or 5 additional anti-seizure medications. Started on cannabidiol, and he's really has continued to have either regression or plateauing of his development despite continued anti-seizure medication therapy. So those are good examples of the types, these 3 conditions that we often refer to as epileptic encephalopathies. So the developmental encephalopathy alone, sometimes a term cerebral palsy will be used, or a static encephalopathy, which could occur from acute brain injury perinatally, such as hypoxic brain injury or trauma, or in the boy I showed you, a developmental anomaly that is static and unlikely to get worse over time. And then the developmental epileptic encephalopathies have really a dual impact on cognition, where sometimes the seizures themselves, when they are really more severe, have an impact on their development. And conditions that we frequently see with this developmental epileptic encephalopathy are conditions such as tuberous sclerosis, Dravet syndrome, where when the seizures are exacerbated, they really have marked either regression or plateauing of their development. And then what we sometimes refer to as the epileptic encephalopathies are often early on, have abnormalities. They can occur onset at any age, but most often occur in early childhood. They often have regression, but often improves if you can get seizure control. So there's obviously a lot of overlap of these conditions, and it comes up with the question of when do the seizures have impact on their development? Are seizures actually causing brain injury, or more importantly, in the pediatric world, impairment of normal developmental processes? So as I said, there's a lot of overlap of these syndromes. One can morph into the other over time, but many of them have important implications in terms of identifying what's the underlying causes, as well as what are the likely genetic causes in some cases, and how can you identify these to consider treatments. So just to review again, the epileptic encephalopathies have more established treatments. The outcomes for many of these over long-term are poor, and oftentimes identifying a genetic etiology in many cases really can allow you to target appropriate effective treatments, and understanding these underlying genetic etiologies opens the avenues for more precision therapies, and we'll talk about that a little bit further. And the developmental epileptic encephalopathies, the seizures are really a prominent feature associated with significant neurodevelopmental syndromes. There's a subset of the populations where the seizures really exacerbate the developmental impairment. And then these often have prominent both ictal and interictal abnormalities on EEG, with often very specific patterns that identify an epilepsy syndrome. And the treatment of the epilepsy may correct some or all of the encephalopathy and the developmental impairment. So as we know, in 2017, the International League Against Epilepsy sort of revamped the classification of epilepsy, seizures, and epilepsy syndromes. And they identified specific syndromes as a function of age, and many of which are these epilepsy syndromes that can be characterized as epileptic encephalopathies. And this is just some of the subset of the conditions. I think I advise everybody to look at this website, which is epilepsydiagnosis.org, which really put a lot of work and shows good examples of the definitions of these syndromes. They have great videos of the different seizures that occur in these, as well as the EEGs in these epilepsy syndromes. Again, that are age dependent and have very specific characteristic features in terms of the clinical seizure type, as well as the electrographic or EEG features as well. Over the decades, or the last couple decades, we've now are able to identify specific genes for many of these epilepsy syndromes. And then this is from a review about 5 years ago, or a little bit longer. What are the more common genes that occur with some of these conditions, such as Dravet syndrome, as we know, is primarily SCN1A. Some of the early epileptic encephalopathies, such as that I described in that first case, Ohtahara syndrome, is often due to channelopathies. There are quite a range of underlying genetic causes for epileptic spasms or infantile spasms, what also is referred to as West syndrome. Sort of epileptic aphasia spectrum, which is sometimes referred to as the eponym Landau-Kleffner syndrome, has been identified to be doing specific gene mutations in GRIN2A, which is a glutamate receptor. And there are a lot of other underlying genes that have really grown to identify the causes of many of these epileptic encephalopathies that I'll show you here. And more importantly, a lot has been learned about where do these genes affect the brain and more particularly the neuron, and how do they cause dysfunction. So that there, as expected, many of the early genetic causes of epilepsy were related to mutations or pathogenic variants of the ion channels, and SCN1A or Dravet syndrome was one of the earlier ones. Actually, a benign neonatal epilepsy was identified in the 1990s, or benign familial neonatal epilepsy as an ion channel pathogenic variant. So there's a lot of genes that affect neurotransmitter function and release, as well as ion channels that are kind of expected. But we also now are identifying a lot of genes that are upstream that involve cell growth, cell regulation, development. And actually, one of the early genes that cause a generalized form of epilepsy is mutations in the glucose transporter that cause what looks like a generalized epilepsy. So there's a lot of how we start categorizing these in terms of different classification, understanding the underlying pathophysiology of how the epilepsy evolves. I think it is still an ongoing work that many people are doing at many different levels, both with animal models and in investigations in humans. So as I mentioned, people have tried to categorize these genetic variants that cause epilepsy, the ion transport, cell growth, and genes that regulate cell growth and differentiation, such as the mTORopathies, regulation of synaptic process, sometimes often referred to as synaptopathies, and then a lot of kind of neurometabolic diseases that look at small metabolism of small molecules within and between cells, not only in the neurons, but also in astrocyte and glia, are important in many of the neurometabolic disorders, which we know also have an underlying genetic basis. And then more importantly, now there's a lot of genes that regulate gene transcription, downstream functions such as of gene and regulation and translation that also cause epilepsy. And how that happens in some of these conditions, still we have a lot to learn. So I think it's important to know that many of the genetic variants that we identify really help us identify treatment. So Dravet syndrome, which is one of the earlier genetic causes of epilepsy, is well-defined phenotype. It's exacerbated by classic sodium channel drugs. So avoiding sodium channel agents is really important. And there are very well set protocols of what drugs are most effective in this disorder. And then whereas there are other ion channelopathies such as SCN2A, SCN8A, and the potassium channels that actually are exquisitely responsive to sodium channel agents. And so it's important to, when we identify those at a genetic basis, we can actually target therapy based on studies that are ongoing and by epidemiological studies. KCNT1 is a drug that is a pathogenic variant that responds to quinidine. And what we're learning now is understanding the functional impact of a lot of these genetic variants, not only the gene in question, but whether it has loss of function or gain of function, how it modifies really is going to really alters our approach to treating these individuals with these underlying genetic causes. So when it comes to genetic testing, how do we approach it? And I think this is an ever-changing field because the availability and the ability to get testing is changing over the time. But the typical approach is we often start with what's referred to as a chromosomal microarray that looks for significant variation in the chromosomes, either deletions or duplications in certain regions. This really has a fairly high yield in patients with epilepsy, intellectual disability, and autism, or with they have other dysmorphic features. It's still important sometimes to look at karyotype because the current genetic testing may not see, major rearrangements in chromosomes. So there's a severe epileptic encephalopathy that's due to ring chromosome 20, and you need to look at those by traditional karyotype. There's single gene testing if you really feel that everything fits right. And for example, Dravet syndrome, I've certainly diagnosed a few Dravet syndrome just by sending the SCN1A single gene, and that can sometimes be done. But more commonly, there are genetic panels that are focusing on epilepsy. And then more recently, exome sequencing really provides the most data and often highest yield in terms of a diagnostic yield. But there are still some challenges when you do exome sequencing. It may miss some of the copy number variants, things like trinucleotide repeats. And it also may provide you with a lot of other variants, what's the dreaded VUS or variant of uncertain significance. And what are you going to do when you find a variant that doesn't really fit the clinical syndrome of the epilepsy? And then more recently, genome sequencing is becoming more and more common, even at a clinical level. So as I mentioned, the microarrays we often do early on, particularly individuals who have epilepsy plus other either comorbid cognitive or other congenital problems. And it has a diagnostic rate of anywhere between 3 and 20%, depending on the patient population and the phenotype. Again, the most commonly used is next generation sequencing panels that have a higher rate of diagnostic findings, but also may lead to frequent variants that are of unknown significance. A study that I was involved with, the diagnostic rate in general overall, and this was throughout multiple centers throughout the US, was around 28 to 30%, either using the broader genetic panels or exome sequencing. I think it's important to recognize when we identify underlying genetic causes, it really changes our therapy. So conventional epilepsy therapy, you identify the phenotype, you identify the epilepsy syndrome, the seizure type, you review that data and obviously the imaging, and then it's kind of a trial and error treatment based on the type of seizure, type of epilepsy syndrome as well. When now with more precision epilepsy gene therapy, if you have an underlying genetic cause, you can identify specific, what's the underlying gene, have functional assays been done either on the specific pathogenic variant, and they can be done in animal models, or nowadays, a lot of functional assays are being done in pluripotent stem cells to identify specific targeted therapies, even from the individual patient. So it allow you to use targeted therapies based on knowledge of the underlying molecular basis of that particular child's or individual's epilepsy. So I think, as I mentioned, genetic testing options are single gene testing, which I think is becoming less and less. Gene panels which are ever changing because the number of genes that cause epilepsy and other problems keeps changing all the time. or exome sequencing, and more recently, whole or genome sequencing is being used. The challenges with exome sequencing are, you're able to look at the whole genome. You often need to do parental testing to look to identify if variants are inherited de novo, or if they are truly likely pathogenic variants, or are they variants of uncertain significance. So the extra work it takes to do exome sequencing or with large panels, it requires often testing not only of the individual patient, but also preferably parents or other family members. This is a study that we were involved with here at Seattle Children's, where we looked at early life epilepsies and onset of epilepsy under age 3. And this is from about 20 to 30 centers throughout the US, that over 700 or almost 800 patients, over 300 of them had genetic testing. If the epilepsy onset was less than 3, the diagnostic rate was around 40%. And obviously, as I mentioned before, exome sequencing and the large epilepsy panels had the highest diagnostic yield. I think approaching the genetics testing for epilepsy really depends on the epilepsy syndrome. So phenotyping is really important and allows you sometimes to use either targeted gene panels or sometimes in rare cases, would you just look at single genes? But many patients, particularly when they're very early onset and young, they don't have very defined epilepsy syndromes. So then you have to use more broader testing, such as gene panels or exome sequencing, particularly if there's other aspects of the phenotype. So I think, genetic testing continues to be a challenge. It's, how do you find the right test? Insurance approval, the interpretation of findings. What if you have findings? What's the implications for treatments? I think geneticists and genetic counselors often have long wait times. So how do you help gauge your you help with your colleagues to help with providing genetic testing? And then access to specific neurogeneticists is even more limited. So I think it's a challenge for more the broader neurologists of how to do testing. So as a result of that, we actually started an epilepsy genetics clinic here, in 2016, where we included our neurogeneticists here, both at Seattle Children's, genetic counselors, and our epileptologists. So where the epileptologists were really responsible to ensuring that they've had an adequate evaluation and really define the phenotype, and the genetic counselors and neurogeneticists would help define what is the best testing to be done to help to give the best diagnostic yield. And again, patients were selected primarily by our epileptologists who would be included in this clinic. And then we often met as a group to help review the phenotype in more detail, and then followed that by identifying, well, what's the best next step as far as genetic testing is concerned. So, and again, as I said, phenotyping is really important, and that was really best left to the epileptologists and neurologists. And in the first 2 to 3 years of this clinic, we saw about 84 patients. 51 patients had either an epilepsy panel or exome. And you can see in patients who had epilepsy onset of under 1 year of age, our diagnostic yield rate was almost 80%. And then in other patients between 1 and 3 years of age, it was between around 20 to 30%. So the overall diagnostic yield was around 40%. Again, this is a biased population that we obviously was referred by both general neurologists and epileptologists in our group that likely had a higher likelihood of high yield in genetic testing. And again, in this case, in that clinic, we often started with microarrays, often went to a next generation panel Right now, some of the genetic panels for epilepsy include, over almost 1,200 genes. Or we actually developed with our geneticists what's referred to as a custom exome slice that targeted epilepsy genes. And if you didn't get the diagnosis in that first look at those specific genes, you could always look at the full exome from the same testing that was done. And we enrolled a lot of these patients in research studies that we have ongoing here. Fortunate to be here at UW. So Heather Mefford and Bill Dobbins and many other geneticists in this region were able to do either exome sequencing or other studies on a research basis in patients that we couldn't get testing done on a clinical basis. I wanted to just review some recent studies that have been done looking at what are the most common genes being identified as causing epilepsy. So this is a recent review from last year of there's been actually really a global collaboration to look at underlying genes. So this is from genetic testing on over 25,000 individuals with different epilepsies. And then you can't read obviously, but the most common cause of epilepsy in this 25,000 patients was SCN1A. And then, but the top 5 are ion channel disorders. So SCN1A, KCNQ2, and SCN2A are the top 3 channelopathies that cause epilepsy in this large population of 25,000 people with what was felt to be genetic epilepsies. And the next more common conditions were PRRT2, which as some people know, cause an early onset sort of childhood epilepsy and then leads to a movement disorder. And then the other conditions that have a high incidence causing epilepsy are MECP2, which causes a condition called Rett syndrome, CDKL5, and PCDH19. So these are all genes that regulate, have other functional regulations other than ion channels and are really high incidence as causing epilepsy. One of the ones that's pretty high on the list is actually glucose transporter. That is important to know because there are specific underlying treatments. So as a result of this genetic testing, we now can really develop precision therapies based on the underlying molecular causes. And I'm just going to review some of the treatments that have evolved and continue to evolve as a result of knowing the underlying genetic basis. And you can often identify these treatments by looking at them in terms of, are they novel treatments being targeted toward the underlying cause? So one of them, which would be defined as a precision therapy, is either everolimus or sirolimus, which is an mTOR inhibitor, which is now being used to treat regularly the epilepsy in patients with tuberous sclerosis complex, which we know is a underlying genetic cause is due to a mutation in the AKT3 mTOR pathway. There's also, we can actually, based on the underlying molecular basis, use anti-seizure medications that we know specifically are likely to benefit patients with specific genetic underlying types. As I mentioned with SCN1A, you avoid the sodium channel agents, but with SCN2A or KCNQ2, the sodium channel agents are most effective. There's other agents such as cannabidiol, which has been shown to be effective for Dravet syndrome, SCN1A. Ganaxolone is another agent that's again targeting specific underlying genetic causes. Ganaxolone was just recently approved for an epileptic encephalopathy called CDKL5, which their phenotype looks somewhat like Rett syndrome. Some new drugs that I would call have not really been identified as drugs for epilepsy, such as fenfluramine, is a drug that kind of would call as being repurposed, and which in the past, as people may know, fenfluramine was used for weight loss and more for other reasons before, and now it's been shown to be a very effective drug both for Dravet and Lennox-Gastaut syndrome. And then there are many other drugs that I would say are being repurposed, that have been around for a while or have been taken off the market, such as retiagabine, which is a potassium channel agent that now is being developed to target patients with pathogenic variants in potassium channels. Memantine is a drug that targets glutamate receptors and is also being used in patients that have pathogenic variants involving the glutamate, certain glutamate receptors channels. And as I mentioned, quinidine for KCNT1 as well. So you can look at these treatments based on what's the molecular targets. Some are being developed, some are being repurposed from agents that have been FDA approved, but targeting those underlying pathogenic variants. And just to review some of those in a little more detail, I think, as I mentioned, the mTOR inhibitors are being used routinely for tuberous sclerosis complex. We're actually using them now for patients who have focal cortical dysplasias, because we have, for a long time, on patients who have undergo epilepsy surgery, we actually look at the molecular basis for focal cortical dysplasias, and many of them have pathogenic variants involving the mTOR pathway, and therefore it makes sense that mTOR inhibitors would not only help modify the expression of the underlying growth, such as in tuberous sclerosis, but also help control their epilepsy. There's, for the epilepsy called SCN8A, with a specific gain of function, there's a trial which is due to a variation in retiagabine that's being used at this point. As I mentioned, quinidine for KCN2, ezogabine for KCNQ2, and some, again, modification of that retiagabine is being used. And again, as I mentioned, phenytoin and carbamazepine are extremely effective for patients that have SCN2A and SCN8A. So a sodium channel drug actually helps with certain pathogenic variants of sodium channel disorders. There are, as I mentioned, there are many new anti-seizure medications that are being developed under the orphan drug rule of the FDA, so that they can get approval in a relatively short period of time. So cannabidiol, also known as Epidiolex, is, quote, FDA approved for Dravet syndrome, Lennox-Gastaut, as well as tuberous sclerosis. Ganaxolone just got recently approved for CDKL5, which is a form of epileptic encephalopathy where the individuals have a phenotype that looks somewhat like Rett syndrome. And excuse me, stiripentol has been around for a while, but primarily in Europe, but it really has been targeting SCN1A haploinsufficiency very specifically. Fenfluramine also for Dravet syndrome. And more importantly, there's been some interesting underlying causes of SCN1A where they've actually developed novel molecular targets with using antisense oligonucleotides to upregulate the SCN1A protein. And that's now in a clinical trial using some targeted therapies. And then another drug in clinical trial is lorcaserin, which is also a selective sort of serotonergic target being used for Dravet syndrome, similar to fenfluramine. So what I wanted to show you was, as a result of this new sort of molecular revolution and underlying cause, identifying the underlying causes of epilepsy on a genetic basis, how therapies are really being escalated and becoming in a very short period of time. So this is a sort of a timeline of a relatively new underlying genetic cause of epilepsy due to the SN8A gene. So that the SN8 voltage-gated sodium channel wasn't really identified until 1995. In 2012, pathogenic variants, de novo pathogenic variants, were identified in certain individuals with epileptic encephalopathies. A neuroscientist in Arizona named Mike Hammer his daughter has SCN8A and started creating a registry as well as developing a patient advocacy group in 2014. And then they created specific mouse mutants of this, also worked a lot to create iPSCs and cellular models of SCN8A. They had their first meeting in 2015, and in 2019 started doing phase 1 clinical trials, and also has a ASO therapy for SCN1A. So over a relatively short period of time, from 2012 to now, current time, they've developed new drugs targeted at the underlying molecular basis in these individuals with these rare forms of epilepsy. So I think, that's really, a lot of the molecular tools now are available to create treatments based on underlying molecular basis, both at single cell level. There's Scott Baraban, who's down in UCSF, has created zebrafish models of many of the channelopathies and can screen many drugs to see how effective those certain small molecules are in treating epilepsy and in zebrafish and other model organisms. So I just wanted to go back and give you the diagnoses on some of these cases. So Uriah, as I showed you with the double cortex syndrome, he continues to be seizure-free. I would still consider him a developmental encephalopathy, not really having seizures. He's making developmental project. He probably has mosaicism of the DCX gene that we're still looking at on a research basis. The young boy who started in seizures, who had the Oda-Hara syndrome, kind of his epilepsy phenotype changed, and he has a pathogenic mutation in KCNQ2 and was very responsive to oxcarbazepine, which is a sodium channel drug that often is effective in this disorder, but he still has a encephalopathy, but his seizures are better controlled. The second case I showed you, who had what initially looked at like as a so-called benign Rolandic epilepsy evolving into a continuous spike wave or an epileptic encephalopathy, had a pathogenic variant of GRIN2A due to a deletion in exon 5, and it was actually paternally inherited because his father had it as well, and he's relatively well controlled on anti-seizure medications at this point, but it still remains to be seen what his long-term outcome is going to be. And the second boy who had early onset epilepsy in infancy, which was more initially a developmental epileptic encephalopathy that sort of changed into an almost continuous epileptic encephalopathy with a continuous spike wave of sleep. He also has a pathogenic variant of GRIN2D and continues. Actually, his seizures are better, but he has significant developmental delays with relatively fair control of his seizures at this point. I think another important reason that it's important to identify these underlying genetic causes is that this really provides patients and families with support groups. So through the Epilepsy Foundation and the AES, there's a group called the Rare Epilepsy Network. There's literally 40 or 50 small patient advocacy groups, and sometimes patient run, sometimes that some are international, some are here and just in the US, that can really work together. They create registries, they support research based on their underlying condition, and they often create a community so that the patients and their families know that they're not the only patients and individuals with these rare conditions, and can help with supporting not only earlier diagnosis, earlier treatments and targeted treatments, but also many of these disorders have a lot of comorbidities, and being able to work together as a community has big impact on patients and families who often have these rare underlying causes of epilepsy. And so this has been, an important aspect of when we make earlier diagnosis. We can connect families and patients and their families with other individuals, and they can get a lot of support and help keep up on the latest research, as well as, provide further information regarding registries to patients and families. And it also stops what we often refer to as the diagnostic odyssey. We don't need to do more and more MRIs, further testing to identify the underlying cause. Now you know the underlying genetic basis. It, again, allows you to target both therapies, keep up on the literature, and enroll patients in clinical trials, particularly as many new targeted therapies are being developed. And this is what has really changed our clinic here at Seattle Children's, is that we've gone past the point of being diagnostic focused in our epilepsy genetics clinic, and we've actually are now converting our epilepsy genetics clinic to a neurotherapeutics clinic, where knowing the underlying genetic cause, now we can help identify patients, provide them with resources for support, identify either clinical trials that we are doing ongoing here, or introducing them to potential other places that might be doing clinical trials. So I think, just to kind of wrap up, so these developmental epileptic encephalopathies are a complex group of disorders that typically have early onset in early childhood, but can have onset at many different ages. They're often frequently have comorbid neurodevelopmental and cognitive problems. A genetic etiology is common, and so as many studies being done with epilepsy onset under age 5, there's likely a 30 to 50% diagnostic yield. I think identifying a genetic cause really often leads to targeted treatments in certain cases, ends this diagnostic odyssey, and provides patients and their families with links to support groups. I think what's happening now is that now we're diagnosing a lot of these rare conditions. We're treating them with rare anti-seizure medications or targeted therapies. That's going to be important. How do we transition these patients to our adult colleagues? And I'm open to suggestions, since we have many of our adult colleagues listening to this, hopefully. All right. So I'm open to any questions.
Hey, Rusty, I had a quick question. This is Tom Bird.
Yes.
Thanks so much. A wonderful presentation. Very informative, fascinating. You briefly mentioned a couple of times having to wait for insurance coverage. Could you just elaborate on the cost of the panels and the exomes and insurance coverage and non-insurance coverage, and how you negotiate those problems?
So this is where having our colleagues in genetics makes a big difference, because they're very used to dealing with insurance companies, making argument to why these testing should be done. And as you know, Tom, that there's the American College of Medical Genetics and other groups now are putting guidelines that, for example, for intellectual disability and for other broad neurodevelopmental disorders, exome sequencing is the diagnostic test of choice. And so as it takes a while for more insurance companies to sort of get on board, but by going back and forth, making the arguments, providing the more recent updated guidelines, we can often get genetic testing done. Fortunately, also here on children's, we have a lot of options to get philanthropic support for doing this testing. But if you look at the cost of a exome, either exome or a large panel, it's no different than an MRI or a one or 2 day stay in the epilepsy monitoring unit. So you can make the argument from a neuroeconomic standpoint that if you make an earlier diagnosis, it may not lead to further MRIs that aren't necessary or other neurodiagnostic testing that may cost more. And there's actually been studies done that have looked at that. So particularly in the early infancy and neonatal period, people are doing what's called rapid exome sequencing and have looked at the neuroeconomics and how that changes therapy over time. And that you can make an argument to insurance companies that earlier diagnosis changes medical management and sort of ultimate outcome. And they've actually shown from an economic standpoint, it saves money for insurance companies. This is an ongoing challenge, and it's a little bit easier in the pediatric and at children's because we have the philanthropic support for doing testing, or also being here at UW, we also have the option of getting testing done on a research basis. But fortunately, both through genetic counselors in lab medicine here, as well as genetic counselors that here work at children's, they're very facile at sending appeals, putting the right information into your clinic notes to likely get approval as well. I hope that answered your question.
No, excellent. That's very helpful.
Yeah. Any other questions? Yeah. So, and I know this is more of a challenge on the adult side to get approval for testing as well, because there are often different criteria for getting testing for when in adults. All right. All right. Actually, I'm off to clinic. Or anybody else have any questions?
Thank you for a wonderful presentation, Rusty.
Okay. And I know some of those patients come your way, right, Shaheen?
Yes, they do. Yes, they do.
Okay.